Dear President, dear colleagues, good morning. Good afternoon. I'd like to thank the organizing committee for the honorary invitation to talk about radical prostatectomy versus radiation therapy for high-risk prostate cancer in men over 75 years old. Under the label of high-risk prostate cancer, actually, we include every case which is at least a clinical T2C stage, or patients with PSA over 20, or patients who present with a Gleason score of 8 at least, or grade group 4. There is accumulating evidence which has established the role of external beam radiation therapy plus 2 to 3 years of ADT in this category of patients. Therefore, this is strongly recommended in EAU guidelines. However, radical prostatectomy over the last years has gained in popularity in this setting, and you can see here in this retrospective study that when especially it's combined with external beam radiation therapy or ADT, it has very good 10-year cancer-specific and overall survival rates, quite comparable with external beam radiation therapy. And recently, there is evidence that radical prostatectomy could suggest a viable option as a monotherapy. In this study, you can see that 88% with T3 prostate cancer were offered radical prostatectomy without any adjuvant therapy and had very good cancer-specific and overall survival rates. Actually, overall survival was even better than the one of external beam radiation therapy. Actually, the concept is that any patient who could be fit for radical prostatectomy could be offered this option actually as a part of potential multimodal therapy. This is a strong recommendation in EAU guidelines as well. For the time being, since we do not have randomized clinical trials to compare the options of radical prostatectomy and radiation therapy, as you can see in this meta-analysis, which includes retrospective studies, it seems that the combination of radical prostatectomy and radiation therapy is better than radical prostatectomy or radiation therapy alone in terms of disease-specific survival. But what is the case when our patient is older, when our patient is over the age of 75? If you look at this epidemiological data, you can see that elderly men have the highest prevalence of prostate cancer, and elderly men have the highest mortality of prostate cancer. In this large database, you can also see that older patients are more likely to have high-risk prostate cancer diagnosis. In this data, which includes 13,000 patients, it seems that 26% of patients who were older than 75 years old had presented with high-risk disease, as it was shown through a Capra score of 6 to 10. However, older patients were less likely to receive definitive therapy for high-risk prostate cancer. Is it correct? It seems that it's not, because a poorly differentiated prostate cancer or high-risk prostate cancer, if left untreated or treated in conservative means, it carries a high risk of cancer-specific mortality of 25% in 30 years. So high-risk prostate cancer is a fatal disease, but the question is that at the age of 75 or more, which is more fatal, the disease of prostate cancer or the comorbidities of the patient? This is a question which we need to answer when we have to treat such a patient. In order to do that, we use some tools. This is a widely accepted tool, the G8, which has been created just for older cancer patients, and its components give information about food, weight loss, mobility, neuropsychological problems, BMI, drugs, patient's self-evaluation and age. And there is a score, the maximum is 17. If the patient has a score of over 14, he is considered to be in group 1, which means fit. And such patients, old but fit, could be offered definitive treatment as younger patients, even frail patients through this G8 scale. If their problems are reversible, they could be considered fit for definitive therapy as well. However, this is not the real-world practice. Unfortunately, here we have a very large database, and the conclusion is that although 2 out of 3 patients did not have any comorbidities, which means that they were categorized as fit or group 1, according to the previous G8 scale, less than 50% of them received definitive therapy. Why does this happen? Are we afraid of doing a radical prostatectomy in such patients? Is it that dangerous? The answer is that it's not a dangerous operation nowadays, because the experience is pretty high. In this large retrospective study, you can see that although the mortality rate over the first month was statistically more than the younger patients, it still remained very low, less than 1%. And older patients had some cardiac or respiratory, but not very serious problems, which means that radical prostatectomy is a safe procedure and carries very good functional results in terms of potency and continence after the procedure. Regarding the latter, continence, I mean, you can see here that it was gained as quickly as it was in younger patients. And regarding radiation therapy in older ages, in ages over the 75 years, you can see that as radical prostatectomy, it's a safe procedure as well, with accepted toxicity regarding acute GU and GI complications, as well as late and complications in the gastrointestinal and genitourinary systems. Besides radiation therapy plus ADT showed very good results in terms of overall survival. And you can see here that when these two modalities were combined, ADT for 6 months, in patients with minimal or without comorbidities, meaning group 1 in G8 scale, the combination was better than radiation therapy alone. Inversely, when the patients had severe comorbidity, then radiation therapy had better results regarding all-cause mortality, possibly because of the toxicity of ADT and the increased risk of myocardial events, especially in older patients and especially in patients who had already such myocardial problems. Besides, ADT harbors increased risk of osteoporotic fractures, which is a problem as well for older patients, as you can see here. So, in conclusion, it seems that older patients do benefit from definitive treatment, Even patients at the age of 75 or 80 years old benefit strongly from radical prostatectomy and radiation therapy, and these two modalities have very good results in life expectancy and quality adjusted life expectancy, but mainly for patients with mild or no comorbidities. So we're talking about two very good treatment modalities who are here to complete each other, and everything is done in favor of patients' benefits. Thank you for your attention.